As we all know, there is no family in India not touched by the cancer issue, and it is emerging as one of the leading health care problem. In fact, as of Indian Council of Medical Research, we have about 1.5 million new cancer cases every year, and at every given time, about 3 times of that number of patients living with cancer. But that is according to the statistics, but there can be much more number than actually we count. And it is not just the number of cancer patients, but this is gradually increasing too. And this accounts almost 50% of these cancer patients are succumb to the disease too. And if you look at the cancer problem in India, this picture is from a recent publication about 3 years ago, published in Lancet Oncology, looking at change in incidence of cancer from 1990 to 2016. And it has shown that the number increased from 63 to 81 per lakh population. And if we look detail into that, the map of India, we can see as far as cancer is concerned, there are almost like a different country within a country. And depending on the developmental status of that population, the incidence also increases. What that says is that if the trend continues, the incidence will reach the level of a developed nation like a US, about 400 per 100,000 in the near future. So we have to do something about that. Another problem is that it's not just a number. The stage of the cancer diagnosis also is different in our country. Only about 30% of the cancer is diagnosed at early stage, and about 70% are diagnosed at advanced stage. This has got a significant impact in the outcome. If you diagnose cancer at the early stage, the cure is almost like 80%, but that drops to about 20% if you diagnose at advanced stage. So early diagnosis is key to make a difference in the cancer outcome. It is not just the diagnosis alone. Another problem, the second major problem we are facing in our country is the lack of adherence to a standardized clinical protocol. There are various reasons behind that. I've listed 4 of them here, starting from the awareness, not only by the public, but the doctors to infrastructure and so on. But if you look back and look at the cancer, we can see that the cancer is evolving or developing almost like a parallel stream to the rest of the healthcare. So for us to make an impact in cancer outcome, to improve that compliance treatment and so on, there is a need to integrate primary and cancer healthcare. So that is essential. Now, how 𝐂𝐀 is trying to address these two major problems. One is early detection of the patient and improve the adherence to standardized cancer care. We believe that we can do that by decoupling knowledge base, the knowledge base to execute cancer, to that the execution side of the cancer, and connect the two using a technology platform. I will come to these 3 elements separately. Our focus is taking cancer care to the people, focus on early detection, and using the knowledge base, provide a very standardized cancer care wherever the patient may be. Now, coming to that execution arm of cancer care, as I mentioned at the beginning, it's extremely important that we integrate cancer care with the primary healthcare or remaining healthcare. So 𝐂𝐀 believe in a participatory model where we want to associate with the various healthcare providers at different levels of cancer care delivery, starting at the community level, establish daycare community cancer center that forms the anchor point for early detection, supportive care, and so on. Then L3 center will be community cancer centers where most common cancer care is provided closer to the patient home. L2 would be a dedicated comprehensive cancer centers where almost all the cancer centers care will be managed. And L1 will be the research and apex type of cancer care. And all this can be supported using that digital platform, which I was talking about with the digital pathology, centralized treatment planning, genomics and other advanced diagnostic and tumor board and so on. All this can be connected using a digital platform, digital to connect with the cancer execution. And what this does is taking the cancer care to the people. And if you do that at a tiered fashion, we believe that the number of people needs to go to the Apex Cancer Center. We can name some of them in our country. Can be limited to about 10% of the entire cancer population. Remaining 90% of the patient can be managed and must be managed closer to the patient home. If you do that, the time travel to seeking cancer care can be dropped from 8 to 10 hours to about 3 to 5 hours. And out-of-pocket expense can be dropped significantly. And more than anything, we can increase the early detection, thereby improving the cancer outcome as well as the cost of treatment. Now, to back all that up, we need to have a knowledge base. Knowledge base is there at the moment, but it just stays within some of the Apex Cancer Centers. So we want to bring that knowledge base into our 𝐂𝐀𝐑𝐄 knowledge central architecture. This needs to be done in multiple areas. One is genomics and precision oncology, then central command center to coordinate the activity, pathology and lab medicine to make the diagnosis, and consulting board experts so that the experts anywhere in the country or world can help to make that decision for a specific patient, wherever that person may be. And then more than anything, we have to look for the future. Future not only for cancer treatment, but innovation when it comes to education and so on. So the Central Command Center is the execution arm of that knowledge base. So a state-of-art innovation center is currently being established in Ernakulam with the various components, including training and research facility that also will house a digital pathology and teleradiology center and central command center to coordinate the care of individual patients seeking cancer care. And what connects that the knowledge base and the execution arm is what we call 𝐂𝐀. That is the technology platform pulling all the data together and then take care of individual data sets to address individual problems the patients or the treating doctors face. And we strongly believe in open source principle and create knowledge not only by treating the patients within the network, but pull the data from knowledge from outside being generated and using AI ML to augment that the decision making and connect all that to the outside world to API and other technologies so that people can use the database wherever that may be, within the 𝐂𝐀𝐑𝐄 network or outside the network. But all this we have to do with the very, very stringent data privacy and security that is already established. Now, what I am going to do next few minutes is going to talk to you actual what we have achieved so far. Our clinical operation started in April, and I will take you to the state of Kerala. And our plan is to have about 70 community cancer centers at different levels, L1 to L4. And within the state, I will take you to 2 of the districts, and then I will take you to one of that the L4 centers, and then talk to you about an individual patient's the care pathway. So between the 2 districts, that Idukki and Ernakulam, we chose specifically these 2 districts because Idukki do not have any cancer treatment facility, but Ernakulam district has the highest number of cancer treatment centers in the country. So we chose 2 divergent type of population, and these are the different cancer care facility at different level of complexity being established, starting from the Tata Hospital in Munnar to an Aster Medicity in the Cochin, and various other cancer treatment centers. And within the cancer, that one of the centers, if you just focus, this is a citizen's journey. Using various outreach activities, people come to know about the cancer care. They do self-checking, and the people are referred to the L4 centers, or we reach out to the people using a command center assistance. And once they reach either within the community or within that L4 center, patient undergo a very structured diagnostic set for these 5 common cancers. If the screen positive, undergo diagnosis within that L4 center. If the person is diagnosed with cancer, with the help of a navigator, referred to different places, and then we digitally coordinate the care throughout the cancer journey of that particular person, or reassure the person that he or she do not have cancer risk. And just to our plan for the year is to have 16 such centers, and we hope to have 100,000 people screened by various activities. Just focusing on one of the centers, CMS Center, started activity in August. In 1 month, over 300 individuals were screened. 12 of them were screen positive, 28 were cancers. And these patients are in different stages of treatment. We hope to have about 3,600 screening to be carried out within a year's time. And our focus is on cervical cancer elimination. Dr. Shankar will explain that fairly soon. Now, lastly, just 2 minutes, let me explain that we do not only focus on the problem we are facing now, but we want to look at the solution to the problem in the future. If you look at the cancer care or cancer treatment, it's a data science problem for the community level, to the individual patient undergoing the treatment, or a cancer tissue getting diagnosed, or within the cancer tissue, how the treatment interacts and so on. It's a data science problem. And to address, so to look to evaluate that problem, we need to have a very structured method of integrating the data. Not only just cancer data, that's what's happening now, from the healthy to high risk, pre-cancer, after treatment, and all that is coordinated by our central command center. This, we believe, will give an insight for cancer treatment as well as diagnosis for the future. We hope to have the world's largest cancer biorepository in the near future. Starting this year, we'll have about 25,000 tissue, and within about 4 years, we will have 1 million tissue and well annotated tissue that will help us to address the cancer problems of the future. So thank you very much for your attention, and we will take up other questions during the discussion time.
Thank you, Anviti. At the moment, for 2021, we estimate around 14 lakhs of new cancer cases and about 8.5 lakhs of deaths. And at any given time, including the new and old cases, what we call as prevalent cancers, we estimate there will be somewhere around 27 lakhs of cancer patients living at this point in time. Okay. But if you break down this total numbers into individual cancer sites, the most important cancer sites are breast cancer, which accounts for almost like 1.8 lakhs of cases a year, new cases, and oral cancer, which accounts for 1.4 lakhs of cases, the uterine cervical cancer, which accounts for 1.2 lakhs, lung cancer around 75,000 cases, and large bowel cancer around 66,000 cases. So these 5 cancer sites account for 52% of all cancers occurring in India. And if to this list, if you add esophagus and stomach, this will further go up to another 10%, so 60%. So if you focus on preventing some of these cancers like oral cancer, cervical cancer, lung cancer, colorectal cancer by various lifestyle changes, like preventing obesity, promoting physical activity, avoiding tobacco and alcohol, eating healthy diet, and all those things. And then you early detect some of the cancers like oral cancers, breast cancer, large bowel cancer, cervical cancer, then one can substantially bring down these numbers, which will have the maximum impact on the overall cancer load in India. So that will have a telling effect on cancer control for this nation.
Thank you, Avanti. That's a very important question. Now, coming to the reason for late diagnosis, the key word here is access. Access for several reasons. Access for the general public to get cancer care or cancer diagnosis, and access for the medical professionals to get cancer diagnostics to their reach. Now, one of the first reason from the public side is that lack of awareness about the 5 common cancers Shankar sir a few minutes back explained. And these cancers have got a very specific high-risk features. These are not really educated to the public. Now, coming to the doctors, there is a problem. One of the main reasons why cancer get delayed diagnosis is that the medical doctors are not trained in oncology during the medical training. So there appears to be that there is 2 parallel streams, one by the general medical practice, and second, a parallel stream for oncology care. These 2 have not integrated well. Now, if we can empower the primary care to diagnose cancer, the impact will be tremendous. Now, some years ago, Dr. Shankar sir published a paper looking at the outcome of one of the common cancers, that's mouth cancer, in Mumbai versus in US population. And he has categorically showed that if you diagnose cancer in Mumbai at early stage 1, stage 2, the cure rate is about 76%. And that in US is about 80%, almost comparable. So using the existing infrastructure, we can cure the cancer, provided we diagnose early stage. So this is a low-hanging fruit. This can be achieved by simple technology. So let me get into that 5 cancers which Shankar sir mentioned a few minutes back. Oral cavity cancer doesn't need any new technology, anything, just one pair of eyes, trained eyes, look inside the mouth. Again, Dr. Shankar sir's work has shown that a health worker by training can diagnose oral cavity cancer, as well as improve the cure rate by close to 30%. No medical intervention had that kind of impact. Now let's take the breast cancer. Simple clinical examination followed by mammogram, ultrasound, and FNAC or biopsy can diagnose it. Now coming to cervical cancer, now we have a technology. I'm sure that discussion will come a bit later by HPV testing, and vaccine is there. This is a cancer which we potentially could be eliminated. Colon cancer, FIT test, simple checklist, high risk, low risk, then a FIT test can diagnose. One of the emerging cancer which is difficult to diagnose is lung cancer. Yes, that's a challenge. Again, there are symptom checkers. So summing up, we need to empower the general public, at the same time empower the primary care doctors too. So if we can integrate primary care and cancer care, we will have a tremendous impact.
We know cervical cancer is caused by persistent infection with one of the 14 human papillomaviral types. If you know the cause for a particular disease, you can prevent it, and you can eliminate it by introducing this intervention in a massive manner. And similarly, if you can identify a woman who is already infected with HPV infection by means of HPV testing, we can focus all our early detection efforts into that particular lady and prevent cervical cancer. And even if somebody develops an early invasive cancer, or if they have a precancerous lesion, what we call a stage 0, or a CIN3 or severe dysplasia, one can treat with very simple outpatient treatments, which will result in 100% cure rate. So I believe cervical cancer is potentially eliminatable in India, provided we stick on, we make investments according to the prescription by WHO for global elimination of cervical cancer, that you vaccinate 90% of the girls with 2 doses of human papillomaviral vaccine by the age of 15 years, and screen at least 70% of the women at ages 35 and 45 with a high precision test like human papillomaviral testing, and then treat 90% of the women detected with cervical precancerous lesions or cancers with appropriate treatment, one can really eliminate cervical cancer. This is not a myth. This is a reality. And in fact, there are countries which have implemented this in right earnest, like Australia and Finland. They will eliminate cervical cancer before 2030 or 2035. The WHO requests all member states to implement these interventions by 2030. Okay. Now, coming to India specifically, India is a large country with a highly heterogeneous population, highly varied health services, with tremendous deficiency of infrastructure and providers in many parts of the country. So if we have the political will, and if you invest in the right manner, beefing up infrastructure, procuring vaccines, procuring HPV testing tests, and then improving our infrastructure for diagnosis and treatment, in vast tracts of this country, we can also be on the pathway to elimination. But for the same reason, India is highly varied. There are some regions of India like Kerala, Sikkim, Himachal Pradesh, and places like that have a very high potential to eliminate much more faster than, for example, UP or Bihar or Chhattisgarh or Jharkhand, where the healthcare infrastructure and resources have to be considerably augmented. And the good news around the corner that India will be producing its own vaccine, and it is most likely to be licensed by middle of next year. This vaccine will be highly affordable as compared to the vaccines which are produced elsewhere abroad. So when we have all this opportunity, implementing this in the right earnest into our health services will eliminate cervical cancer. In addition to this, doctors like gynecologists, primary care physicians, pediatricians can also prescribe human papillomaviral vaccine. They can practice screening in their clinical offices, which will add to the public health efforts by the government as a support mechanism, and which will be a fantastic public-private partnership. And via the voluntary sector, the private sector, the doctors' organizations, the governmental infrastructure, and everybody work together towards a common goal, cervical cancer can be eliminated in this country. It may take some time, but some states will eliminate it faster. But other states, they have to make substantial investments to eliminate. So I will call it, it is a reality, provided you make the right investments.
Several countries, in fact, countries such as Taiwan and others, by putting across effective measures of cancer prevention and early detection, whether it is in the form of vaccination for hepatitis B, for chronic infections, and or other aspects such as tobacco control programs where lung cancer incidences could be reduced, or even coming to the fact of introducing other vaccinations such as HPV, or even promoting good health in terms of physical activity and others. Several such forms of cancers have been amenable towards prevention. So this is absolutely critical. Unfortunately, this requires a huge sort of shift in terms of behavior from moving away from the construct of illness and concentrating on wellness as a imperative here. And there has to be multiple implementation partners who will have to come together to really make this a reality. If we really look at this as an approach, how can we achieve this together? And ecosystems and platform thinking will have to come together. Now, if you look at public-private partnerships, a lot of private players, whether it's hospitals, technology partners, or even institutions such as Karkinos, a lot of digital platforms can in fact bridge this gap and bring novel technologies in order to bring the awareness messages with respect to wellness and bring all the participatory systems together. Nudging people and reminding them in terms of the risk factors and helping them avoid that. And if they did, making them conscious of physical activity and others will actually make a tremendous difference. Having said this, this alone will not obviously solve the problem and lead towards early detection. What is additionally important is governments and public setups also implementing policies, bringing vaccinations, insurance companies and others reimbursing for some of the early detection programs and diagnosis. All will have to be coming together in order to enable and reduction with heavy health expenditures which otherwise exist today. I think this will only become a reality if we move towards universal healthcare situation where everyone gets all the adequate necessary infrastructure and resources towards prevention. Today, which does not exist. So if there are adequate resources allocated, technology coming together, this can truly become a reality. So looking forward to wellness being a construct than just a focus on illness, I would say.
Move the thinking from illness to wellness. If you do that, the cost of cancer care can be tremendously decreased. Let me give a story, narrate a story. So I'm a cancer surgeon. I do head and neck cancer surgery. When I was working in Bangalore, I had a lady came all the way from Bellary to Bangalore to treat a very advanced cancer. Our group was very well known for that. So that's why she traveled. So I explained about the surgery involving half the face needs to be removed, can't swallow, disfigurement and everything. Okay, she patiently listened to everything and she just about to leave my office. She just turned back and asked only one question. Question asked how much it's cost. She didn't ask, I'm going to live, I'm going to have disfigured, nothing. The cost is a major problem. And Dr. Shankar Narayan sir mentioned about the number of cancer. It's more than 1.2 million in our country. And that number is going to go up go up to the incidence rate. Currently, it's about 80 per 100,000. That will increase to about 400 per 100,000. That is happening in the developed nations. So that number we will reach because our predilection for cancer is similar to any other humans in the world. So we will get that high incidence. So we have to focus on reducing the cost. Otherwise, Indian economy will not be able to stand. That lady I spoke to, she cannot bear that cost, and the country will not bear the cost. How we can do that? First thing, as Sripriya mentioned about prevention. Prevention makes sense. Now, if we can't prevent, as we discussed earlier, these 5 common cancer can be detected early. Then third part is even much more important. Let us say cancer is a reality, we're going to get it. But unfortunately, almost 3/4 of the patients in our country do not get standardized protocol-driven treatment for various reasons, access I mentioned at the beginning. So that needs to be, cancer care needs to be protocol based. That should be implemented and standardized throughout the country. It's easy to say that, but to executing that will be a challenge. We do not have the resources to make hundreds of data memorial hospitals throughout the country. That is not possible. Now, how we can empower every hospital, almost every hospital, as a cancer treatment facility? It is possible. It is a necessity. Unlike in the past where the cancer is a rare disease, it is no longer. 1 in 10 of us will develop cancer. So this should be treated almost like any other common disease like hypertension, diabetes, cardiac disease, and so on. Most of the hospitals should be able to empower to execute cancer care. That is why 𝐂𝐀 is thinking about developing that tiered cancer care model. Only about 10% of the patient needs to go to a hospital like Tata Memorial Hospital or RCC Trivandrum or such major hospitals. Almost remaining 90% must be and can be treated in a remote place, provided we use technology, embrace technology to do that. So India is well known for our technological capability. So using several technology, I will not go into details of that. We will be able to empower, we should be able to empower primary care doctors to cater for most common form of cancers.
Healthcare actually is moving to point of care. And when I say point of care, to where patient is or closer to the patient. And what we are trying to do in this next GenWorks journey, as we define tomorrow today, the tomorrow of healthcare is clearly point of care, to move to where the patient is from a situation where we have right now or in the past, where patients had to move to where healthcare was delivered. So now this is all about changing access. We believe that as in GenWorks, we believe that it's very, very important to be able to provide healthcare closest to where the patient is, because that's when it's truly accessible and that's when it can be affordable as well. In all the solutions that we have, specifically to this discussion about women's cancer screening solutions, we have the technology. We could put together technology where we could look at a problem very early through the screening technologies that we have for cervical screening or for oral or for breast screening. All of this can provide early access. All of these are devices that can be used by a paramedic, trained paramedic, and can be supported by AI at one level and remotely connected to a specialist anywhere in the world. This gives us immediate access for early screening and early diagnostics. And then what next? This is the big question that has to be answered, because when we find a problem, we have to provide a solution to the problem, which is treatment. There is a level of treatment. In this case, in cancer, 80% of treatment can be provided locally. If 80% of treatment can be provided locally, that means the same place where the problem is diagnosed, the treatment can start. It of course needs a support. This is where 𝐂𝐀 comes in. the true value of 𝐂𝐀 comes in, because they create an oncology department within a nursing home or a gynecology setup. And when they partner with the gynecologist to be able to provide that 80% care that can be provided in-house through their experience and through the infrastructure that they have established to be able to bring in this connected ecosystem. And this significantly reduces cost burden, because number one, early screening happens, early diagnostics happen, treatment also happens, and in case it's a late stage treatment which needs tertiary care, here again 𝐂𝐀 will support the patient and the healthcare provider to be able to go to a nearby tertiary care and not leave the patient to fend by themselves. So there's a significant partnership. This connects our story, and we believe that GenWorks, next GenWorks, has to do a lot more as this. And here we are for women's cancer, and of course, in all of the care areas that we are trying to bring in this infrastructure, we will also bring in support for treatment, because treatment is the final cure, and we cannot be responsible about that. And this thereby is a responsible partnership, and I'm sure this is going to significantly improve healthcare access, affordability, and definitely save lives.
So I'll be talking on the use of technology in nephrology, and I will limit it to one area, which is home hemodialysis. But before I start, I was told that it's a combined audience. So for those of you who are not into the medical field, nephrology is study of kidneys, and kidneys are bean-shaped organs which are of almost the size of a fist, weighing about 140 grams each. They are on either sides of the lower back, and each of these kidneys is made up of million such nephrons. So, and these are the structural and functional unit of the kidney, where the exact functioning of the kidney takes place. And it is because of this, it is called as nephrology. So to be more specific, we study the functioning of the kidney, which is otherwise the in effect the nephrons. So as you see here, it's basically full of blood vessels. And for an organ which just weighs about 140 grams, you have about 25% of the output coming from the heart. The output, I mean the blood that is coming from the heart, goes into the kidney. So per gram weight, this has the maximal blood supply. And rightly so, because it has to excrete whatever waste is generated because of the body's metabolism. So we eat food, and that food is converted into the energy which is required for the functioning of the cells of the body and as a whole for us to be functional. Now, to be very precise, the size of the kidneys are around 9 to 11 centimeters in length. And once the kidney is damaged, they get smaller and smaller. So we call it as shrinking of the kidneys. Now, these are the spectrum of kidney diseases that we normally see in a nephrology center. The major ones are acute kidney injury, chronic kidney disease, nephrotic syndrome, which is nothing but leakage of protein into the urine, nephritic syndrome, which is leakage of blood and proteins in the urine. And of course, we see a lot of electrolyte and acid-based disorders. By electrolyte, I mean problems related to either high or low sodium, high or low potassium, problems related to disturbances in the calcium levels in the blood, phosphorus levels in the blood, magnesium levels in the blood, and so on. And by acid-base disorder, I mean that we look at whether there is an acid buildup in the blood or whether there is a deficiency of acids or whether there is a lack of acid in the blood. And these are things which we commonly see. There are others too. When we look at it, the majority of what we see in a hospital like ours, a tertiary care center, is chronic kidney disease. And unfortunately, chronic kidney disease does not have any specific treatment, and this is going to progress over time. The best as a nephrologist we can do is to try and slow the progression. So we have classified this into various stages. The last stage is called as end stage kidney disease, or CKD stage 5B, we call it now. Now these are the procedures or therapies that we do. Predominantly it is dialysis through a catheter, kidney biopsies, and dialysis. You have two types of dialysis: hemodialysis, or otherwise called as the blood dialysis; peritoneal dialysis, otherwise called as the stomach dialysis. And today we have a special field of nephrology called interventional nephrology, where we do create fistula which is needed for hemodialysis. And then whenever there is a problem with the fistula, it's like the heart angioplasty, where there is a narrowing of the fistula. We can go and then balloon it and make the narrowing disappear, and this is called as fistuloplasty. And the same when it occurs in the blood vessels supplying the kidneys, we call it as renal angioplasty. And of course today a lot of noise is there on point of care procedures. So scanning of the kidneys is now picking up. We call it as point of care ultrasonography. So these are the common procedures that are being done in a nephrology unit. So as I said, my focus today will be on chronic kidney disease. So chronic kidney disease is coming up like a pandemic, and when you see in elderly people, you have good 20% of men and 25% of women having chronic kidney disease, and the prevalence increases as we age. So in a nutshell, if we have to look at the prevalence of chronic kidney disease, irrespective of the age of the individual, it's about 14% in women and 12% in men, slightly higher in women. The problem with chronic kidney disease is that there are no symptoms, or even if there are symptoms, these symptoms are very non-specific. So it is difficult for somebody to go and say that this is probably related to your kidney disease. And that is the reason why there is a gross delay in identifying chronic kidney disease. Most of the times we do identify chronic kidney disease when a blood test or a urine test is being done for a totally different reason. And today, pre-placement examinations or medical examinations are very common. And whenever somebody undergoes a surgery or an executive health check, people get a creatinine test and a urine test done. So we do identify chronic kidney disease at a very early stage. But unfortunately, we do not have any specific treatment. So our focus will be predominantly on to try and see whether we can slow the progression of the disease and make the person healthier compared to somebody who has not had diagnosis of chronic kidney disease very early. Now, as I said, most of these diseases that we deal with are not treatable, or the treatment is very toxic, or the treatment is very costly. So it is very difficult for people to follow the care plan. Now, on one hand, the prevalence of chronic kidney disease is increasing tremendously. And on the other hand, the workforce, which is basically nephrologists and the whole team, is actually shrinking. So this is a survey from 121 countries to look at the density of nephrologists per million population. PMP is per million population. So if you see, it is very high in the European countries, North America, Brazil, and South America, Australia. So predominantly the developed countries have a very high density of nephrologists, while the developing countries have very low density. So take a look at most of the African countries here, India and the South Asian countries, where we hardly have 4 or 5 nephrologists per million population. So this is high density countries, and here the nephrologists are very, very scarce. And based on income, if the income of the country is very high, then the density of nephrologists is more, and it just drops down as the economic prosperity comes down. So India is still considered as a low income country. So this is see the distribution. The Western Europe and North America have the highest density of nephrologists, while Southeast Asia and Africa have hardly 1 per million population in terms of nephrologists. It is actually dwindling in developed countries too. Look at what has happened to the nephrologist population over years. From 1996, it is coming down, and it's sort of stabilized somewhere around 40 in United States. On the other hand, you see this greenish line where the prevalence of end-stage kidney disease, as I said, is rapidly on the rise. And the same is in United Kingdom and in Canada. So these are probably the most advanced countries in terms of medical facilities. Now, I mean, this is a very busy slide. It says these are all the threats to the doctors taking up nephrology as a specialty. But at the end of the day, to me, these two things stand out. Yeah. Effort intensive area. So we need a lot of time to be spent with the patients, and the remuneration is significantly less compared to the other counterparts, and so it has become very, very unpopular as a specialty. And unfortunately, this is a very, very bad sign. The International Society of Nephrology is breaking its head to see how we can sort of make the medical students and the physicians take up nephrology as a specialty. So hopefully in the coming years, things should improve. Otherwise, it's a very, very grim area. And the reason, as I said, for poor access to nephrology care is that there is a very high disease burden and there is a shrinking workforce. So I showed it there. And non-availability of specialists in many areas. If you take India, there are many states which do not have a single nephrologist. That is the plight. So when the nephrologist numbers are very less, then obviously the waiting time to get an appointment to see a nephrologist is very high. In fact, if you look at countries like Canada and United States and UK, it takes months to get an appointment to see a nephrologist there. So in India, it's the other way around. You get to see them a little early, but as I said, there are many states in the country which do not have a single nephrologist. So the plight is very, very bad in our country also. And the moment somebody is detected to have kidney disease, most of the primary care physicians tend to refuse to see them because of the complexity involved in taking care of these patients. And of course, the treatment is, the cost of treatment is very high. And in a country where predominantly it is the patient who spends out of his pocket for healthcare, non-affordability is a major issue, especially in the low-income countries. Now, when we talk of chronic kidney disease, as I said, there are only two treatment options. One is dialysis, and the other is kidney transplantation. Again, dialysis is not very widely available in the developing countries. And I mean, in the economically weaker countries. And even if they are available, the facility is inadequate given the number of people who need them. And so rationing starts happening here. And of course, there are gaps in terms of monitoring all these patients. And of course, when we come to dialysis, I said there are two forms of dialysis. One is the hemodialysis or blood dialysis, and the other is peritoneal dialysis or the stomach dialysis, which can be done at home. But unfortunately, in countries like ours, the acceptance of peritoneal dialysis or home stomach dialysis is very, very important. And when it comes to transplantation, the number of centers doing transplantation is very less, and there is a significant organ shortage, not only in our country, but it is a problem all over the world. So when we have so many issues in terms of care given to a patient with kidney disease, technology can help to a great extent. So I look at it in these ways. One is e-consultations. Second is remote patient monitoring. Third is encouraging peritoneal dialysis and home hemodialysis. Then use of artificial intelligence to improve the therapy. And of course, when we look at hemodialysis, which is probably the most common form of dialysis, as I said, we need something called as an AV fistula, and this is probably the Achilles heel of that particular form of dialysis. Because of repeated punctures, they get clotted, and it's a big headache. Once we get into a nephrology unit, we realize that this is a very major problem. And one of the things that can probably happen is use of robots to do AV fistula cannulations, because these robots can be designed to go to angles which are not possible for human hand to cannulate this fistula. So a lot of good will happen to patients if we can probably use robo-assisted cannulations. But I'm not going into the details of all these things. E-consultations is now happening, and especially so after the COVID pandemic stuck, I think teleconsultations are becoming more and more popular. So with the availability of teleconsultations everywhere, then a lot of people who have to travel hundreds of kilometers to see a nephrologist can manage their disease through e-consultations. So that is probably one area which should improve. So straight away I will go into remote patient monitoring. When I say remote patient monitoring, this is basically in relation to peritoneal dialysis, hemodialysis, and home hemodialysis, which is now coming up in a big way. So what is remote patient monitoring? We use evolving technology to do a real-time examination of a patient's clinical status from their home or any other healthcare facility where a specialist is not available round the clock. So this allows a unique insight into the clinical status of the patient between clinical visits. And many a times we can advise interventions before the patient starts deteriorating. So this is the uniqueness of remote patient monitoring. And as a result, there is a huge potential for improvement in patient outcomes, be it in peritoneal dialysis or be it in home hemodialysis or satellite dialysis units. Today, almost every district headquarters in many states like Karnataka, Tamil Nadu, especially southern states, do have dialysis facility. And the problem there is that they do not have a nephrologist who's able to monitor all these patients during dialysis. So a remote monitoring will be very, very useful when it comes to monitoring those patients who are getting dialyzed in a satellite unit away from the place where the nephrologist is. And I will go into it little in detail about what technology we have as of now, and probably over discussions we need to try and improve on these technologies. So before starting a remote monitoring program, there are certain things that we need to be very clear about. So we'll have to include all the team members. To me, the nurses, the technicians. I'm telling this because in India, hemodialysis is predominantly done by technicians, whereas in the developed world, it is predominantly done by the nurses. Patients, then the caregivers of the patients, and the physicians who are involved in the care, which includes the nephrologist and the primary care physician. So all these team members should be included, and then they will have to brainstorm to decide what data we are going to collect, how often should we collect, and then what is the trigger threshold for an action. So these things are to be brainstormed, and then there has to be very clear-cut clarity in what we are going to do. And of course, we should have technology in terms of Bluetooth-enabled devices like blood pressure cuffs, weighing scales, and other scales which we will know as I show the pictures. So they should be available. And of course, you should have Wi-Fi, cloud computing, and all those things which will help. These are all available in most places. And we should be very careful, because with every parameter that we monitor, you get more data. And if there is huge amounts of data, it will overwhelm the providers, and as a result, it will limit adoption. So we have to be very, very clear as to what is very critical in terms of day-to-day management of that patient, and what will actually give us a very good outcome. for the patient. So these are things that we need to be very, very clear about before starting a remote monitoring program. And of course, today we have facilities for dialysis therapy parameters and alarms to be monitored real time. I will tell you about that. So we are using that in our hospital. So these are some of the things. This is not an exhaustive data. Depending upon what is the condition of the patient, healthcare condition, then we can look into what are all the major things that we need to monitor. For example, if somebody has asthma and related lung disorders, then we need to monitor their spirometry and the oxygen saturation. Similarly, if somebody has heart failure, then we have a lot of other parameters to monitor. Diabetes, we can monitor the blood glucose levels, and then these can be automatically transmitted. Peritoneal dialysis, today we have a cycler which can transmit data to the parent unit on a real-time basis, and we can directly help the patient to circumvent the problems that arise during the course of a dialysis session. Same is true for hemodialysis. So this is the automated peritoneal dialysis machine. So peritoneal dialysis, for you to understand, what we do is we surgically put in a soft catheter into the abdomen. So the cavity is called as the peritoneal cavity. And then we instill fluid into the peritoneal cavity. This is the dialysate fluid. And then the blood vessels which supply the peritoneal membrane, they bring the blood to that cavity. So there is a diffusion and convection that occurs between the blood in the blood vessels of the peritoneal membrane and the dialysate. So we prepare the dialysate in such a way that what is necessary for the body is there, and what is to be removed from the body is not there in the dialysate. So it diffuses out. What is the waste that is accumulated diffuses out of the blood into the dialysate, and what is essential like sodium, potassium, calcium, magnesium, chloride, bicarbonate, sugar. So all those things are there in the dialysate so that the blood levels of those are kept in the normal range. So once we instill X amount of fluid into the peritoneal cavity, we leave it inside for the exchange to occur across the membrane. And then after a given dwell time is what we call, then the dialysate is taken out of the body and a fresh quantity of dialysate is instilled into the peritoneal cavity. So this is called as an exchange. Now this is the machine. This you have to download what is called as the share source. So this can be downloaded in the peritoneal dialysis center, which is there in the hospital, and it will be also connected to the home choice machine, which will take the data of what is happening during the dialysis, including the alarms. So they will be transmitted through Bluetooth into the share source thing, and then the clinician can see it in his. The patient can also directly coordinate with the PD nurse who will be there round the clock in the hospital, so they can guide them as to what needs to be done, issued. So this is just coming to India. I think we have the previous version of home choice where we do not have the share source, or it is not compatible. So the patient only has to write down what is the input and the output. And then once in 6 weeks or 2 months, once the patient comes, we go through his book that we give them, And then the TDMS can also communicate with the hospital health information system. And then that will provide data for the quality management system of the hospital. So this is now being more and more used. So then the next aspect of this TDMS is the therapy monitor. So each patient is given a smart card. So the dialysis in charge enters the patient details. Then the patient, what is the dialysis therapy that the nephrologist has prescribed for that particular patient. And the moment the patient's weighing scale is also attached to this card. So the patient brings in the card, puts it in the weighing scale, and then its weight is checked. And the moment the card is taken out and put into the dialysis machine slot, then it sets the dialysis prescription that has been pre-filled in that card. And then the whole dialysis activity, minute by minute, is there inside the card. And this TDMS, which is installed in the desktop of the nephrologist or in his iPad or smartphones. So the nephrologist can just log in and see what is happening in the dialysis unit. So this is an advancement in the regular dialysis area. And the major advantage is that the amount of data that is gathered by this system. I mean, today we have the big data analysis coming up in a big way. So artificial intelligence and all can be used to analyze the huge amounts of data, which will not be possible manually for any one of us to sit and do. And then we can probably refine the therapy based on the outputs that we get from the data analysis. So I'll go to home hemodialysis. This is now becoming more and more popular in the developed world. The reason is it can be done at their homes. The timing is flexible. So employment problems does not occur. And people can undergo dialysis daily. They need not travel to a dialysis center. So the moment we get more frequent dialysis, it is like the regular kidneys working. So the blood pressure control, the phosphorus control, everything is very good. So as a result, the number of medications that we prescribe to all these people come down. So as I said, it gives that feeling of freedom, flexibility, and control of the treatment, rather than the dialysis center controlling what time you come in, what time you go, and things like that. So as I said, the possibility of more frequent dialysis, 5 to 6 times, or nocturnal dialysis is also there. And the most important thing is that there is no risk of an acquired infection. So when you look at a hemodialysis center, you have machines close to each other, 20 machines, 25 machines close to each other. Everything has blood in it. So a lot of infections like hepatitis B, hepatitis C, etc. can be transmitted to patients if somebody else is infected. But here, because it is for an individual, for him alone, the chance of acquired infections becomes zero in this home hemodialysis setting. There are about 3-4 machines that are available for home hemodialysis. This is one. This is called as NX stage or next stage hemodialysis machine. They're very compact. They're very easy to use. And this is another one which is available. As I said, home hemodialysis is something that we cannot give for everybody. So the person and his caregiver, the nephrologist, the nurses who are taking care of the patient have to be willing to learn a lot about it, and more so for the patient and the caregiver. And they have to be willing to take responsibility of their own treatment. And then there is a rigorous training, and they should pass the rigorous training. And this includes how to place a fistula needle themselves or their caregiver. They are very easy to use. If you see, that is the size of the machine. It is very easy to use. It is very easy to clean and disinfect these machines. And today, with refinement in technology, the supplies that somebody needs to store at his house is also very less. And these machines are portable, if you see that. So they can go and sit or lie down wherever they want. They can just move the machine and then get dialysis done there. And the most important thing today is that these machines allow significant water conservation. So when we do a regular hemodialysis, we use about 150, 160 liters of water. Whereas when we go into this home hemodialysis with these miniature machines, the water used is 93% less. So when we look at gallons, it's about 143 to 6 gallons of water. So this is very, very important because we are going into a stage where there is going to be a huge amount of water scarcity. So this is another machine, user-friendly. But for a home hemodialysis to succeed, the patient has to find a center and a doctor who is willing to train them and follow the care. And at the same time, the patient and the caregiver should be committed to learning it and doing it for at least a year. And subsequently, it will be very, very easy. In our country, we do a different form of home dialysis. So this is the regular dialysis machine. So we can set up a small dialysis facility. Today we have a single unit water treatment plants, and all you need to do is to buy a machine and keep it at home. A little plumbing work is required, but they're all not a major issue. And in general, a technician or a nurse goes to the patient's house and then does the dialysis for him. We have it in Bangalore, we have it in Chennai, we have it in Delhi, we have it in Mumbai. Most of the metropolitan cities do have this sort of dialysis, but this is not the actual home hemodialysis. This is a dialysis that is done at the luxury of your house with a technician or a nurse. One of the major hurdles that we have is that the number of people who are requiring care in terms of dialysis is increasing. The number of centers offering dialysis is very, very less. Then there is a great shortage of nephrologists and the dialysis therapists. So we might have to go in for hemodialysis, home hemodialysis in the long run. This is feasible. It has been done successfully in the developing countries. More and more people are accepting home hemodialysis in the developed countries. Of course, it will take some time to get into our country, but I think it should not be a major issue. So we still can adopt home hemodialysis as a mode of dialysis therapy. Of course, peritoneal dialysis using cycler is happening, but I think the acceptance should be much more. The Third thing is transplantation. Transplantation, the issue here is availability of organs, and as a result of it, we need to keep patients on dialysis. So there has to be a tremendous work done in the area of dialysis. So satellite dialysis have to come in smaller places, and they have to be linked to a major dialysis center, and software will have to be there to help the hospitals to monitor the dialysis that is happening in the satellite units. So this is something that has to come, and it will come over a period of time, because the need is there, and it is still fully not met. So there are a lot of unmet needs in the area of nephrology. I'm just looking at only one aspect of it. There are multiple other aspects which actually needs to be addressed too. Hopefully, yes, it will get addressed in the future. Thank you for your...
I would like to cover in this session for the next few minutes on how GenWorks is enabling the access, and how we are looking at bridging the gap through the technology advances in nephrology. So basically, like Dr. Padmanabhan sir told, disease burden is very high. There are a lot of CKD patients, 𝐂𝐀𝐑𝐄 and a lot of other kidney-related disease. There is low awareness, as doctor was saying, till the screening happens, or master health checkup, or the patient goes for any other tests. They are not aware about the kidney disease at all. Limited specialist availability. Very few nephrologists available in the country, that especially in tier 1 and metro cities, whereas we know that 60+% of population is in tier 2 to tier 3 cities. So what do these people do without access to nephrologists? Do they have to travel hundreds of kilometers to see nephrologist? And especially patients with kidney problems, it's going to be a very, very difficult scenario for the patients and their relatives. Lack of skilled staff, especially for running the dialysis center, nursing, dialysis care providers, and allied services staff are very limited. And even dialysis centers are limited and very less treatment options. Only, dialysis or transplant, or very limited treatment options, and lack of preventive tools. So with so much of challenges in the nephrology care area, we were thinking, how do we enable the access? How do we bring the connected care? And for this, we basically need to bridge the gap with multiple stakeholders, and we need to bring in so many of this technology aspects, education, and a lot of things we need to bring in to really get the connected care across the country. So what GenWorks started doing is really, putting together what are the gaps and how do we bridge those gaps. We are providing and we are bridging the gap through the partnerships. GenWorks has been successful in providing this kind of partnerships where we bridge the gap in the care areas, in cardiology or in OB/GYN, oncology care. And very well, we have done this very successfully. So why not in nephrology? That's what we thought. So we started putting together the partnerships, and we bring in the best-in-class partners and put together the entire ecosystem. That's basically what we do. So we bring in we have a range of IVD products which can do markers, the kidney function test, and a lot of other tests which are required for early diagnosis and early screening of point-of-care screening for kidney-related disease. We bring in a lot of devices, connected devices, Bluetooth-enabled devices, and the devices which are going to help in managing the kidney patients, blood pressure device and diabetic meters, and a lot of the devices which are required to monitor and screen the patients. Then we partner with Renalix. You heard from Dr. Shyam Vasudev Rao, Managing Director of Renalix, on how they have put together fantastic technology, which is an IoT-enabled dialysis machine. In fact, Dr. Padmanabhan sir was talking about the technology, but when you see the currently available technology is all about patient having a SD card and they have to put it in the machine, the dialysis machine, and then they have to take it out, and then that will be transmitting the patient information to the doctors. This is the limitation of the current machines and current technologies are available. But what Renalix has done is Renalix has innovated a dialysis machine which is IoT enabled. So you don't need to have all these SD cards and Bluetooth enabled devices. It directly transmits the dialysis information to the cloud, and through Tele-Nephrology Platform and NIS platform, the Nephrology Information System, which is built in, it can transmit all the information, all the patient's details, and in a secure cloud. And a doctor sitting in tier 1 city or any other place can view the patient. So this is very simple technology, but very, very powerful innovation. And of course, Renalix is working on bringing home dialysis. So it's a very powerful partner and very, very important partnership for us. They're also partnering with another company for manufacturing these products, because when you manufacture dialysis machines, one of the key aspects is maintaining the high standards of quality. It has to be best in class when it comes to the quality and affordability, because the dialysis is a lifestyle. It has to be managed through the life, and it's very, very expensive procedure to be maintained throughout the life of a patient. So it has to be very affordable. So we are putting together that partnership of manufacturing these machines. And then we partner with large universities like Manipal, Mahe, and Amrita to put together training programs along with NU Hospital and few other leading skill development organizations to put together a training program for staff, skilled staff. You need a lot of dialysis technicians. You need a lot of dialysis nurses. So we have to put all this training and bring staffs, allied services staffs in tier 2, tier 3 cities. Any corner of the country should have dialysis technicians, should have nurses qualified for doing the dialysis. So that is another partnership which we are putting together. And once you have this, then you need a partner to provide the dialysis services, because not every nursing home or hospital even in remote places or even in tier 2 places may want to run the entire dialysis unit. So we are tied up with one of our very key partner, NephroWorld, who are one of the leading and fastest growing dialysis service providers in the country. And they provide end-to-end service, and they're very patient-centric. High quality dialysis protocols and procedures are being followed by NephroWorld. So it's again an important partnership for us. And clinical specialist, once you have the dialysis services being run by NephroWorld, you need the specialist care. NU Hospital is one of our partner, and we are also partnering with few other hospitals, but NU Hospital being a tertiary care specialty nephrology hospital has a lot of very, very qualified and renowned nephrology specialists. So we are partnering with them to provide remote nephrology specialist and complete treatment care. So if patient wants to get transplant done or further diagnostics and further treatment, they can be referred to NU Hospital. Or the patients are far away north and other places where NU Hospital is not having specialists, we are tying up with the local specialty hospitals. And also follow-up care, because follow-up care is very important, because when patients are located 200, 300 kilometers away from the specialist, they have to be managed properly. So monitoring the patient on periodic basis and patient management is very important. So we have a platform. We are tying up with a few more specialists to put together a follow-up care protocols and methodologies. And we are working with our own team, and the team from Renalix are working on providing the Tele-Nephrology Platform. And it's not only Tele-Nephrology, it is also connected care. You have to connect end-to-end. You have to connect all the patient parameters, screening. You have to be on top of their lifestyle, and a lot of other monitoring parameters need to be properly maintained for the specialist to take care of the patient. So we provide the complete technology, and we work with Renalix on that. And also we are working on the lifestyle management protocols, where the medication, diet, and physical activities, and which will make the patient prolong their life, right? And minimize the impact of dialysis. So that's again another important area where we are working with few other companies. And the artificial intelligence. And this also Dr. Padmanabhan sir touched upon, where AI will play a very important role in prediction of dialysis of kidney patients, kidney disease, and prevention of kidney disease. So we are working with Genesis, one of our leading partners in AI space. And we are also working with NU Hospital in providing this AI tools for the doctors. So if you see what basically GenWorks does is putting the entire end-to-end ecosystem and connecting the entire care cycle to provide the nephrology care, bridging all the gaps. So with this, what we can achieve is we can achieve a completely tech-enabled hub and spoke model.